A little bit better. Hi, everybody. Good afternoon. It's nice and cool in here, isn't it? Thank you, Kristen, for bringing the refreshments today, especially the iced coffee. That's a nice little treat. Thank you. We have Kristen Reed today, who's here from BI Deaconess Urgent Care. I'm sure it has more words in that title. You'll fix it. Okay. And she's here today to talk about wound care and basic first aid. Thank you, Kristen.
Thank you guys very much for having me. Let me find a spot for this. Okay. So yeah, as Debbie said, my name is, can you guys hear me? Do I need to be closer? Closer? Okay. My name is Kristen Reed. I'm the nurse manager for the Beth Israel Lahey Urgent Care in Dedham. We're on 1A, so not a super easy building to find. I'm happy to give any of you directions if you want them, but we've been there for about 3.5 years and started to sort of do these presentations for our community. So thank you guys very much for having me. I'm going to talk today about basic first aid, titled Burns, Scrapes, and Bruises. In your bags that you guys have, there are little first aid kits. So as well as some notepads, some information about us, and a little safety light if you're out walking in the evening. It's just a little flashing light so the cars can see you guys. So that is in there for you. And I'm told that this is being recorded so you guys can relax and reference it later. So again, thank you guys very much for having me. And we'll get going. So we're going to start with the basic anatomy lesson. So we have our skin. It is the largest organ in your body. Treat it well. So we have 3 layers of the skin. We start with the epidermis, which is sort of the outermost layer of your skin. And that is basically the safety part of the skin. That is the protective part. That also contains your pigments, and it is an important part of your immune system. The layer below that is going to be your dermis, and that is where your nerve endings, sweat glands, and hair follicles come from. And then below that is your subcutaneous tissue, and this is your connective tissue, blood, vessels, fat, sort of everything underneath there. So we sort of think of injuries that we want to sort of identify when they're affected by each of these sort of layers, how you would manage them. So I apologize ahead of time if anybody's squeamish. There are a few pictures in here. So we have different wound types. The first one being here, an amputation. We're not going to cover anything about that today. That is hopefully nothing that anybody here has to manage. And then we have an avulsion, which is basically where you have sort of a large piece of skin taken out where you can't, well, you say approximate, bring the edges of the wound together. We have crush injuries where there really isn't a loss of any of the skin, but it's just more of like a compression, and that's going to give you your bruises and your things like that. Abrasion is more of just sort of a scuff where you take off that sort of top layer of skin. So that's going to be your skin knees, your kid road rash injuries type of things, and then a laceration where it's more of a straight cut down through multiple layers, but where you can actually bring the edges of a wound together. So based on how, which sort of type of injury it is, there's going to be various ways that they're going to be managed. So a laceration, or fancy word for a cut, is basically where none of the skin is missing, but it just has been trauma. There's trauma where there's a cut there. So you can bring, again, the edges of the skin together. They can be superficial, like a paper cut. Nothing really needs to be done. Keep it clean, keep it covered, versus a large cut where you would need sutures, multiple layers of sutures, etc. So depending on the cut of the wound, the care will vary from basic Band-Aids to stitches. Obviously, the first priority for any sort of injury is going to be to stop the bleeding. And if there's not a lot of bleeding, then just make sure that it's nice and clean. So cleanse the area, soap and water. That's always what we recommend. People come in and think that we have all this fancy wound cleanser and things like that. Basic soap and water, everything you have at home. And then obviously if there's a lot of bleeding, then direct pressure to the wound. So variable sort of things that will cause you your ability to stop the bleeding is going to be a lot of people, older folks, sorry, are on medications, which may affect sort of the bleeding. So we think of things like Coumadin, Xarelto, aspirin, sort of any of your anticoagulants are, by their functionality, don't make it so your blood doesn't clot as quickly. So with your mechanical valves, your AFib, your history of stroke, things like that, that is good. But when you have a cut or an injury, that doesn't necessarily allow for your bleeding to stop quickly. So again, it's going to be direct pressure. Sometimes a bandage would be enough, but if not, if it's really a lot of bleeding, then actually like manually putting pressure on that wound. If you can get it to stop bleeding in a timely manner and it doesn't seem like it's a very deep cut, then just home management for a small cut would be fine. Obviously, something that is bleeding excessively that you can't get it to stop at home, then it would be seeking out care at an urgent care or an emergency department, depending on time of day and extent of the injury. As far as some of how the management is, so if it is a deeper cut, then we will put stitches in it. The big thing with stitches or sort of any permanent closure of a wound, we always want to do that within the first 24 hours of the injury just to prevent infection. Once it's been open for longer than that, there's a high risk of there being bacteria within the wound that we would then basically be closing that up and keeping that bacteria in there. So if you have something that you're concerned might need stitches, it's always important that you get that evaluated within the first 24 hours, because otherwise they likely won't close it up unless it's like a very severe sort of gaping injury. So once sutures are placed in, it's basically you're just going to keep good care of the skin. So basic hand washing, washing of wherever the wound is, antibiotic ointment for the first few days, and then petroleum jelly after that. You're going to want to keep it covered with like a non-stick gauze. You can normal bathing, showering, letting water run over that area. We don't recommend certainly scrubbing at them because that can pull on the stitches. And we also don't recommend like bathing or swimming or prolonged submersion into water because the skin softens up and then the stitches can pull. So we always say just like showers or basic washing of that area. And then also a lot of people have various things that they think they have at home that they are important to use for skin care, but hydrogen peroxide is one of those things that's probably in just about everybody's medicine cabinet. It's fine when you first have an injury. It's good for sort of helping, the bubbling will help get any debris out of a cut or a wound. But after that, once the skin starts to heal, sort of that bubbling and effervescence of it can actually break down some of like the fresh granulation tissue. So you never really want to use it more than directly right after the injury to help clean it. So it wouldn't be something that you would want to use continuously to keep a wound clean, soap and water after sort of the initial injury. And then the biggest thing that we always recommend is sunscreen. Once the healing is completed, that is going to cut down on your scarring. So sunscreen is a really important part of wound care that people don't often think about. And then really stitches are going to be left in, depending on the part of the body that they're on, anywhere between 5 days and 10 days. So places like the face are going to be less time. It heals faster, but you also want to have less scarring, versus like hands are going to be like 7 days. Joints like knees or something like that may be as long as 10 days. So depending on sort of how much movement there is in the area, how thick that skin is going to be variable of how long a stitch stays in. But that would be part of a teaching at the time of after they were put in. So moving on to something that is a little less invasive than stitches that does work quite well for smaller superficial wounds that maybe don't go all the way into the epidermal layer, maybe just as sort of like a deep dermal injury, is going to be something like steri strips. They call them like butterfly stitches. And basically it's strong tape that basically holds the edges of that wound together and allows them to heal. The big thing about it is that they are basically a tape-ish type material. So putting any ointments or anything on that is going to loosen that adhesive, and they're not going to stay on as well. Once they're on, you can leave them open to air, wash it gently with soap and water, but you don't want to, again, scrub anything like that. And then you can keep it covered with just a basic gauze. And one thing that I did not have in here, but we do use also is called Dermabond. It's basically like a fancy super glue for skin. And that can be used also, we use it a lot in children because it's not quite as traumatic then to also have to have them come back to take stitches out and things like that. But it's a glue that we can put on a wound and basically hold the edges together, and it will allow for sort of quicker healing, especially if it's an area that's like bleeding a little bit more, that a Band-Aid or something like that may not stay on. So we use Dermabond or some sort of a skin glue frequently as well for more superficial wounds. And again, same thing, once the area is healed, sunscreen to prevent scarring. Right. Pictures, warning. Other sort of getting back to sort of more superficial injuries, these are going to be your abrasions. This is your road rash, your skinned knees, you're just taking off that top layer of skin. So most times it's just the epidermal layer, which is the top layer of the skin. Sometimes it can extend down to the dermal layer depending on how sort of deep, obviously, it goes. But with this, the idea being is that there's loss of that whole layer of skin. There's nothing to bring together. It's going to sort of be just an open area. Big thing with these is just making sure that right after the injury that they get cleansed really well, get out any debris. Often happens from landing on sort of rough surfaces. So outside on like sidewalk, pavement, a hard floor like this probably wouldn't necessarily give that abrasion because there's not anything actually to like that's rough that's gonna cause sort of that injury. So again, making sure that after it happens, you clean the area really, really well. If it's a small area, a Band-Aid. Otherwise, on top of it, like a non-stick dressing or a gauze. And then eventually, after a couple days, the idea being is you really do want to eventually get it to stay open to air, because sort of keeping a dressing on something like this it's never going to really dry up, and it's kind of always be that moisture barrier is going to be in there, and it'll prolong the healing period. So keeping them open once they start to sort of granulate or have that healing skin. Am I talking too fast? Can you guys hear me okay? I'm a fast talker. Sorry. Okay. All right. So again, care for abrasions. So an antibiotic ointment and a non-adherent dressing and a Band-Aid, depending on the size of it. A clear or yellow sort of weeping type of drainage is normal. That's just we call like serosanguinous drainage, and that's basically just like the leak from the capillary beds that's in your skin, and that's normal. We'll talk about sort of non-normal things in a little bit. After a few days, you're again going to want to try and leave the wound open to air for periods of time, as that's going to help sort of it dry up and sort of create that scabbing versus it constantly sort of staying damp and never having that opportunity. Again, monitoring for signs of infection. That's going to be your redness, those abnormal drainage, if it becomes sort of surrounding areas or warm to the touch, increasing pain, things like that. So just keeping an eye on them. Next, burns. As someone said, you can get a burn outside today. Absolutely. So burns can be caused, we think of burns coming from more likely thermal sources, so heat burns, but you can also have burns from the cold. So that's like your frostbites, or sort of fall in the category of burns as well. And depending on the sort of the extent of it, it can be, again, just affect the epidermal layer, and that's going to be your sunburns, your really mostly just sunburns. Anything beyond that, or just like a quick touch on something that's hot. And then it can get into the deeper parts of the tissue depending on, again, the extent of the burn. So again, your first degree burns is sort of how they're categorized. So you have first degree, second degree partial thickness, second degree deep partial thickness, and then you have your third degree, which is the full thickness burns. So again, the first degree is just going to be that top layer. So that's going to be your sunburns, things like that. And treatment is going to be just sort of cooling the area off, basic pain control if needed, Tylenol, and like aloe, a little lidocaine gel or something like that for the, because it's intact skin is the idea of a first degree. Second degree, partial thickness is where it extends sort of past that surface layer. So there can be blistering with this. And same as the first degree, it's just going to be, first line is going to be cooling the skin off, stopping sort of that thermal injury. And then applying, if it does have an open area or bubble, applying a non-adherent dressing. And if it is not healing well, seeking medical care. Likely just monitor for infection, and we really recommend anytime that there's an injury that extends beyond sort of the first dermal layer that you consider looking to see if you need an updated tetanus vaccine, just because that you've now sort of permeated down in past your protective skin and you're now into the tissue. So for any of these lacerations or burns, we always recommend checking to see if you do need a tetanus booster. And then once we get into the second degree partial thickness, deep partial thickness, this actually is definitively sort of into the deeper dermal layers. It's going to be more painful, more of a pressure sensation. So this is going to be really more one that you're going to want to seek out healthcare for. So it's going to be sort of the same management of protecting it with non-adherent dressings, the tetanus, but these are going to be the longer healing ones. And then the third degree or the full thickness, these are these are the really bad ones. These are the ones where it actually goes all the way through the dermal layers and into the fat. And then when it gets down this far, basically your body's ability to regenerate the skin is lost. So this is when you are looking more for like the skin grafting and things like that, because the other ones eventually the skin will regenerate and you'll have sort of return of the normal like skin function with all of the layers intact. But once you have the full thickness, there's the inability for this even to regenerate. The part with these is that they also can be painless, because at this point all of the nerves have also been damaged. So this would be something that you would be managed more at like a burn center. So in the Boston area, Mass General and the Brigham have the two big burn centers. If it's a small area, that can be managed anywhere. It's more when you get into sort of large volume areas of the body. So how do we treat them? Again, cooling it off, making sure that you're stopping that thermal injury. So running it under cold water. There is like burn relief that has an ointment that's an antibiotic ointment that also has like a topical lidocaine or something that you could put on there that'll help sort of numb the area a little bit. Any of these sort of non-stick pads, there's a brand name Adaptic that's like it's like a petroleum impregnated gauze so it doesn't stick to the skin. And then a non-stick gauze and wrap. And hydration. Really, anytime you think of that you have a area on your body that has lost its integrity, that's an area that you sort of lose your moisture out of. So any sort of larger areas that have an injury, hydration, and none of us drink enough water, so anything we should be hydrating. And again, for superficial sunburns, things like aloe are good. Yeah, I hear you talking about so there's a lot of sort of wives' tale-esque type of things where people culturally have various things that they put on burns. So I've heard butter, toothpaste, all these different things that people will put on their burns. None of them are good for you. Stick to ice, stick to water, and you don't really and ice is not right. You're going to want to just run it cold water, just because the ice, if you have put ice on something for an extended period of time, you can have the opposite type of injury. You can actually have a cold injury to the skin. And if there's any sort of if the skin is feeling numb from the injury, that you're not going to realize that you're actually potentially causing more damage by putting ice directly on your skin. So you should never ice your skin directly. Always have a barrier in between there, but just cool water, but no butter or toothpaste, mouthwash, all sorts of things I've heard. So toothpaste was one. I'm like, what is all over you? They're like, oh, it's toothpaste. It makes it feel cooler. I'm like, I understand the theory, but I don't know that that's really a great idea. So keep it if you can't find it in the wound care aisle, don't put it on a wound, not the dental care aisle. And then again, for extensive burns, we would always recommend burn centers. They have sort of the specialists, but this is just good information to have. Hopefully nothing that anybody needs to ever partake in. Skin tears. if people don't mind, how many people in this room have experienced a skin tear before? Yeah. So as skin ages, there's less less, there's a word that just went out of my head, sort of your, the elasticity, there's a word, collagen, all of those things that sort of keeps the skin plump and together. And so as people, and also medications, certain medications put you at higher risk for this. Any of those blood thinning medications, people that are on chronic steroids, other things like that, really it does sort of take a toll on the sort of your skin and how it's going to react to even minor trauma. So a skin tear is basically when the top layers of the skin pull back. So they don't actually, it's not necessarily a laceration because the skin pieces of it stay on there. So it's basically pulls back sections of the skin. And they can occur something as simple as like bumping a door frame with your hand as you walk through it, falling, bumping your leg on like the leg of a chair, something like that. It takes very little trauma at times for people to have these skin tears. So again, like any of these other injuries, wash the area with mild soap and water. If it continues to bleed, continue putting the pressure on there. And again, blood thinners, which are one of the things that put you at higher risk for these, will also prolong the bleeding time. We like to see when the skin remains intact. Sometimes we are able to sort of pull, similar to a laceration, we can at least approximate the edges together. That skin, depending on how much sort of the perfusion is still left on that flap of skin, sometimes it will actually like heal back onto the subcutaneous area. Sometimes it doesn't. And that tissue we use it as a cover up to sort of protect the sort of that raw skin that's under it, but it doesn't necessarily heal back down. So depending on sort of the size of it, so we have the different classifications here. So like the type 1, there is like the good approximation. So likely we can sort of steri-strip those depending on the size of it. The doctor may put like 1 or 2 stitches in to sort of just hold the edges together to protect the tissue underneath and hope for the best that maybe they'll sort of they'll heal back together. The type 2 is where you actually have lost a section of the skin, so there is an open area that is no longer sort of protected by whatever sort of skin flap is left. And then the type 3 is there's all of that tissue is gone. Skin tears are challenging because they're going to be very sort of prolonged healing. So again, we may put some steri-strips on to hold the edges together. Again, not putting, if this does happen, if you have steri-strips, don't put any ointments or anything on it because that pulls the adhesive off and they then will fall off. Again, keeping it covered with sort of non-stick pads and using a roll gauze. We like to try not to put tape on someone's skin. It's already proven to be fragile by sort of the type of injury that has occurred. So using sort of a roll gauze that we can just sort of tape it to itself rather than putting Band-Aids or something like that, because the risk of sort of causing more skin damage is there. And then if we're unable to approximate the skin back, we'll keep it covered and with a non-stick. And then I know that BI Needham has a pretty extensive wound care clinic that they have specialists and sort of all different types of specialized creams, ointments, dressing types, things like that will they'll work with people. They'll see them a couple times a week to sort of keep an eye on the progress of any wound, not just for skin tears, but really any type of wound. So referral to a wound care clinic might occur depending on the extent of the injury. And then we have pressure ulcers. So the reason I bring this up, some people may use some sort of like braces or assistive devices and basically in a wheelchair, and really any time that you have something that is applying a constant pressure to your skin, you have risk of skin breakdown. So it can even happen when if people unfortunately are in the hospital and they're not frequently repositioned, people can have breakdown of their heels, of sort of the bony prominences. So we think of heels, we think of people's sort of butts and same idea. She asked if that's a bed sore. So the same idea. Basically, it's a pressure ulcer. There's been constant sort of pressure on an area of the skin that then causes it to slowly break down. So yes, it is. So this is certainly something that we as healthcare providers go through a lot of training and do work closely with sort of the aides and everything to make sure that people that aren't able to sort of reposition themselves in bed well do get repositioned frequently, so there isn't that that constant pressure on sort of those bony prominences. Every couple hours, yeah. Because you think about, even you go to bed at night and you sort of you move around, something starts to hurt you a little bit, you get yourself off that area that's sore. But when someone has sort of an alteration in sensation, maybe like I see people that have like maybe foot braces or some sort of a brace that area is already a little uncomfortable, that a little like pinch of the skin doesn't really phase someone. So just wanting to make sure that keeping an eye on sort of the skin integrity underneath anything. Same thing that we always, when we do any sort of dressings, any splinting, anything like that, that we always want to make sure that there's sort of always a smooth surface underneath something, because that sort of small area of like even a wrinkle in a splint or something can sort of put enough pressure and constant pressure that it can cause a pressure ulcer. So there's sort of multiple types. We've got the stage 1, which is where it's kind of red. When we say blanchable, that's basically something is red, you push on it, it turns white, and then it goes back to red. These don't sort of have that, which is an indication that is like sort of a loss of the blood flow to that area. And then you have the level 2, stage 2, and that's where there's actually a blister and there's been loss of the top layer of skin. And then below that is what we call non-stageable, which is that it is damaged down into the subcutaneous, and the sort of the tissue, all like a deep tract of tissue is dead, basically. What we call eschar, which is when the tissue sort of turns that black color and has no perfusion to it. So pressure ulcers can be, the first obvious line of them is going to be prevention. So incorporating devices that alleviate pressure. So if someone's in the hospital and maybe they can't be rolled on their side because of a orthopedic injury or something like that, we have special sort of boots and splints that we put on that maybe has a cup cut out so the heels aren't pushing on the bed. They kind of are floating in the air. Even using a simple pillow where you would put it under the legs but leave the heels free, so the heels don't that's one of sort of the first places that we see them, is on people's heels. And then also we'll do special dressings that we'll put on sort of especially on the butts, because it's really hard unless you can roll someone off sort of that area. That personally, mine has plenty of padding. My tailbone would not be pushing on a bed, but someone who has sort of less padding, that is an area that's going to be susceptible to having an injury sort of right at the tailbone. And especially someone who's like wheelchair bound, so that we'd use like a special like gel pads and seats covers and everything for someone like that. So back to previously promised. So talking about, once we've sort of talked about all the ways to take care of wounds, various wounds. Most of the time, it goes well. It heals up, takes its time, but you always want to be aware of when something is looking a little bit off. So you can see sort of where those sutures are. You see sort of the surrounding the redness. There's no drainage there, but it doesn't look like a super healthy wound. So things that you're going to look for signs of infection: fevers, feeling just kind of punky. You may not actually have a fever, but just something doesn't feel great. Redness, swelling, streaks of redness. Often they go upward, so towards, because basically it's the infection is going with the blood flow, so it's coming up. So usually we'll see sort of someone has say a wound on their arm, and we start to see lines that travel up. That's concerning for a cellulitis. Purulent discharge, which is sort of going to be your yellowy, greenish, not clear type of drainage. Sometimes can have an odor to it. Dehiscence, that's kind of a fancy medical word for the wounds pulling apart. So at one point it was together and now has separated out. Colors, change in colors of the extremities. So with these, it's important that medical evaluation does occur, because often we'll need initiation of antibiotic therapy to treat. And depending on sort of the extensiveness of the infection, it may be with like IV antibiotics, which would be emergency department, versus oral antibiotics, which can be done through PCP or urgent care. Now we're going to talk about when the skin doesn't get opened up, but there is an injury to the skin. So ecchymosis, another fancy word throwing out there for same thing as bruise. So bruising occurs when there is trauma to the arm, leg, whatever, and the bleeding occurs underneath the skin surface. So you basically have a leak of blood from the capillary beds. So it never actually comes through the skin, but there is like basically bleeding under the skin. It will occur again more commonly with people who are on blood thinners. These are usually self-limiting. It's going to sort of stop on its own. Capillaries are tiny. It's not like a big blood vessel, and they'll stop basically on their own. You sort of the color variability. So directly right after the injury, you sort of have that redness. It then turns that pretty color purple, and then eventually sort of the green to yellow to brown. And that's basically as the, it says right here, the blood is full of iron, and the hemoglobin breaks down into other components, and that's sort of why it changes colors. So icing the area right after you smack your leg really hard, you're like, ooh, that's going to leave a mark. Putting some ice on that, always protecting your skin. So underneath with a towel or something, basically that's going to do, the ice will help shrink down the capillaries. It's going to make that potentially stop the bleeding under there. So putting ice on it directly post-injury will, again, slow down the leak from the capillary bed and potentially decrease the size or the extensiveness of the bruising. And then a hematoma is basically just a big bruise. So unlike the bruise, though, that is caused by the leaking of capillary blood, so just right under the surface, this is going to be where there's trauma to some of the larger blood vessels. Not talking like your arteries or anything like that, but you do have sort of, you have your capillaries, and you have your smaller vessels. So this is with that injury, there is going to be sort of more of that leaking of the blood, which is going to cause sort of a more prominent lump of a bruise. So often caused by more forceful traumas, so a fall, being struck by something hard or fast. Again, anticoagulation or clotting disorders is going to create worsening hematomas, just because there's not going to be, it's hard to put direct, unlike maybe a laceration that you can put direct pressure on something. Trying to figure out where exactly this blood is coming from when it's not on the skin surface is a little bit harder. So making sure that you're putting that, so direct pressure isn't necessarily going to slow the bleeding. And it, again, is going to be self-limiting, but doing compression from an ACE wrap, something circumferential, may help decrease the size of the hematoma. And again, outward appearance like a bruise, but likely with an area of swelling. I talked too fast, sorry. You guys supposed to be here till 1, 2? Okay, questions?
For the hematoma, should we put ice on there also?
Yeah, so she's asking for hematoma ice. Certainly, it's not going to hurt. Icing, sort of like any sort of injury, people always ask, do you ice or heat? Ice or heat? And so we always recommend whether it's with a bruise, a sprained ankle, a sprained anything, ice for the first couple days post injury is going to help. So a bruise or a hematoma, there's going to be that slow capillary leak, and that's what's going to create the discoloration. Same thing when you like sprain your ankle. There's going to be that trauma to like the tendons, the ligaments where they've kind of been stretched, and they will also sort of have that leaking, and that's what causes the swelling. So doing ice will help sort of cause vasoconstriction, so sort of constrict down those blood vessels, and will decrease sort of the overall swelling, the extensiveness of the bruising. So ice post in any injury for the first couple days is always the recommended.
Early on, you had, I recognize Neosporin, you had ABX.
Oh, that's me probably putting something medical on here. Antibiotic. That's a short cut word for antibiotic. My apologies. That was an oversight. Yes. So Neosporin, triple antibiotic ointment. But yes, ABX is, yep, Ensure. Yeah, that is antibiotic. Sorry. Yeah, antibiotic ointment. So just anything that, the big thing a lot of the time, especially with the abrasions where there's sort of a moderate sort of surface skin loss, is that you put just like a plain dry gauze on it, and it starts to sort of dry up and heal a little bit, and then you pull that gauze off, and you basically have now pulled off, your body's worked really hard to sort of start creating that granulation tissue, and then you pull it off and you undo all the work it's done. So putting something like an antibiotic ointment, Vaseline after first couple days, anything to sort of keep that area from drying to or adhering to the dressing that you've put on. They also make, like, again, a non-adherent type gauze that doesn't, they have like Telfa, again, there's the Adaptic. So these are all have like a little like impregnation of some sort of a non-adherent tissue, either again like a petroleum, or like the actual gauze itself doesn't allow sort of the moisture to stick to it. Either, go ahead.
Black and blues. Every time I have my blood drawn, because I'm on a blood thinner, I get black and blues. And if they can't find my vein, I get really severe black and blues, which takes a long time to get rid of. Is there any way of preventing black and blues?
So she's just for people that can't hear, frequent blood draws, people notice that they do have bruising, and certainly again being on a blood thinner is going to create sort of a exacerbation or make that bruising worse. So it's basically because as the needle is going through the skin, it's basically causing micro trauma to sort of all of that tissue that it's going through. And it can then cause sort of that leaking, which is the bruising. So I don't know how, if that's, some people like bruise, some people don't as much. So just again, right afterwards, putting some ice on there may decrease the extensiveness of it, because it's going to sort of constrict down that, those vessels, and also making sure that they do put a good like compression on there right afterwards. So not just like a little Band-Aid on the surface, but actually something that puts a little bit of downward pressure on the puncture area to
Drink water or anything before you have the blood drawn?
yeah, I'm not, I can't speak to that with actual knowledge or not. But do drink water. It's good for you.
Is there anything you can do once you have a bruise to make it go away faster?
Not necessarily. There's a way to prevent it from sort of expanding, which is going to be that ice, a little bit of compression. But sort of once that trauma has occurred, then it's just going to be sort of that tincture of time of sort of that absorption process of the blood being absorbed back down, and the color sort of variation as the hemoglobin and the iron and everything reabsorbs.
When you do have to use ice for a bruise, how frequently should you apply
apply the ice, and when you do apply it, how long should you keep it on the area?
Yeah. So she's asking as far as ice application, sort of the frequency. So we always say 20 minutes on, 20 minutes off. So you never want to keep it on for much longer than that, just because, again, that can be begin to sort of cause some of that that cold trauma from ice, and again, also not directly on the skin. So even just like those like instant ice packs and stuff that people may have in first aid kits, you always want to make sure that you do have just a barrier between that. And on the other side of that is the same thing. We've seen people that may go to bed at night with a heating pad on because their back hurts or something like that. You don't realize that sort of that prolonged direct heat can eventually cause an injury too. So just making sure that you're always aware of any time that you're doing any sort of like heat or cold therapy, that you are awake and sort of alert and aware enough of that skin to make sure that there is not going to be sort of injury related to whatever therapy you're using.
Sunburn, get blistered on sunburn.
Yeah, so some people, so I was saying about blistering for sunburn. So that's going to be sort of when the trauma to the skin is more than just sort of that first degree, which is just sort of effective of the epidermal layer. So depending on sort of, it's going to be your sensitivity, how much pigment you have in your skin to start with is going to be sort of how, going to depend on how sort of much damage that sun can do. So a peeling of a sunburn, most people know if they've had that. It's usually not like a burn where there may be some blistering, but it's usually just like dry skin that peels off. There usually isn't actually like fluid filled, unless you get a really, really, really bad sunburn. But usually it's just like your skin peels and it's just sort of that very outer epidermal layer. It doesn't actually go down into the dermis, which is where you then get the blistering, where you actually have fluid and things that come out. Great shirt, by the way. Took me a minute, but it's a good one. Any other questions? Does everybody know where our urgent care? Not that I'm here to promote our urgent care, but also to promote education. But I'll be up here if you guys have any questions, sort of about our services, what we can do, where we're located. I'm captive for at least another 20 minutes. So, yes, so if you're coming up Route 1, the big intersection where Legacy Place is going to be on your right, there's Convenient MD, the CVS where the Minute Clinic is. We're really located basically in a triangle of urgent cares. You're going to take a left that's Elm Street. And then at the end of that is Washington Street, so that's 1A. And if you take a left there, where the last building before the overpass that goes over 95. We're in the same space as Greater Boston Urology. So some people know where the urology practice is. We're on the ground floor. Or Finnegan's, was that a restaurant that used to be there? I've heard all about Finnegan's. So we're in the old Finnegan's space. So that's where we're located. What? Oh, maybe, yeah. Something like some Irish restaurant. Yeah, it was a fish market. It's been a lot of things. Yeah.
Are you ones that right on Chestnut Street where the hospital is?
I think that one of the primary care groups had urgent care there, but we've only been in that. There's other Beth Israel urgent cares. There's one in Chestnut Hill, Quincy, and Chelsea. Oh, okay. But as far as sort of our group that I've been involved in, we've been there since. So yeah, good question. We are open Monday through Friday, 9 to 7, and then on the weekends we're open 9 to 5. We are staffed exclusively by emergency medicine physicians. So all the same emergency doctors that work at the Beth Israel hospitals cover the urgent cares. We have on-site x-ray, ultrasound, and CAT scan. We have a system where patients can get it ordered through us, and they go right to Dedham and have the imaging taken, and then we follow up on the results, so you don't have to go to the emergency room or anything for that. And we have lab on site and x-ray on site. Any other questions? All right, thank you guys very much. Stay cool out there.